Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again, welcome back. My name is Dr. Tom Dow, and you're about to watch The Bridge to Health. So, for those of you who watched our show before, you realize that The Bridge to Health involves many different team players of many disciplines, which help you get to the other side of the bridge and achieve better health, all working together as a team. I like to explain health kind of like a 5-spoke wheel. If all the spokes are tight, the wheel rolls perfectly straight. If one of the spokes becomes loose, the wheel wobbles, and it affects all the other spokes of the wheel, making them loose till eventually the wheel wobbles so much and the wheel no longer functions. The human body is not that much different. The first spoke of the wheel of health is proper nervous system function. Your nervous system must work properly for that wheel to roll straight. You must have exercise so your musculoskeletal system can stay strong and support your structure. It's important that your mental state, the third spoke, is tight. If you're depressed, if you're pessimistic, eventually that will take its toll physically on your body. Sleep is important. When we sleep is when our body tissues heal. And all of these spokes must remain very strong, and if not, the wheel will not work properly and your health will be compromised. Quite often, when we have a patient come into one of our offices, the patients are in excruciating pain. When you're in excruciating pain, you can't exercise. You don't want to. You can't sleep. You're up all night. Your tissues can't heal and get better even if they wanted to. Your mental state deteriorates. It goes through down to the basement. You get depressed. So one of our team members, thank God we have this team member, is a pain management doctor, Dr. Kachechian, or Dr. K as we call him. Welcome, Dr. Kachechian.
Oh, thank you, Tom.
I'm going to refer to him as Dr. K for the rest of the show. It's a little easier. So welcome to our show, Dr. K.
Pleasure.
And you very often work with our team to help our patients get over that pain threshold so our team can continue to work on the patient and get them across that bridge. Tell me how pain management started. You're an anesthesiologist by training, correct?
Correct.
So how did you get from an anesthesiologist into pain management? What made you decide you wanted to do that?
Right. Back in like the late 80s, pain management was being developed as an interventional, multi-specialty and medical field. And having trained early on as an anesthesiologist, I was looking for more patient contact at the time. And interventional pain management was available as a fellowship. So I did this training to help pain sufferers because I was becoming one myself from sports injuries at a younger age. So that's what drew me into pain management and fellowship to help others with chronic pain, much like myself.
So again, for the audience, pain management is 4 years of medical school, in which you got an MD degree and then specialized in anesthesiology after that?
Right, through residency.
One year residency in anesthesiology, and then you had further training in pain management.
An additional year.
An additional year in pain management. So tell me, what is it like being a pain management doctor? Do you enjoy it?
Very much.
And what is a typical day for you in your office?
Well, it's like a medical wellness concept. We're seeing a lot of patients with neck and back pain primarily, much like yourself in chiropractic.
Right.
And we're finding out that they have quite a story of pain, whether it's from an accident or growing older and having spine disease. And so we put them into this model of care, as we're discussing, this multidisciplinary approach, and try to help them. They're suffering and they're miserable, so we find out their story and offer them help.
And so is your patient base mainly chronic pain patients? Are there acute pain patients? Is there a mix? I mean, what is the mix of those patients?
Yeah, most are chronic. Most injuries start out acute, but if they persist for more than 3 months, they become chronic, and certainly after 6 months. So most are chronic, but It's strange. You're always seeing acute situations anyway because our chronic pain patients have surgeries or they get re-injured. So sometimes it's acute on chronic. So it's a combination, but mostly a chronic process. Every month we'll see them to try to help them.
Gotcha. And your help consists of medication treatment, injection treatment, a multitude of different tools you use. Can you elaborate on those a little bit?
Sure. So multidisciplinary care has developed where you're combining these different modalities, these different approaches. To break it down, in America there's medical pain management, there's interventional pain management, injection management, and surgical. So we have these different specialties.
Surgical pain management.
Very important.
Cool.
I consider these the surgeons that help our pain patients, like you had Dr. Alongion and Dr. Weisberg.
Right.
Terrific surgeons.
Right.
Yourself as a chiropractic.
Right.
With therapy. An interventionalist like myself.
Right.
Anesthesia trained or rehab trained.
Right.
And psychology care, restful sleep strategies, complementary alternative.
Right.
They need multidisciplinary care.
And that's what you do in your practice.
I help coordinate it.
Of course.
Even though I'm trained as an anesthesiologist.
You're part of our team. When we need you, we refer patients to you. You report back to us exactly what's going on. So we're communicating all the time about our patients together.
Teamwork.
So my next question is, we read in the media all the time today about the problem with pain medication and overdose deaths and things like that. That must be a big problem and a concern in a pain management practice. Am I correct?
Very much so. We've used opiates for years and years, even the last 20 years. Big doses, thinking that we had to help patients with their pain suffering, their pain scores, that the risk was smaller than the benefit. And now 20 years later, we're seeing the problems emerge, not only in society with addiction, abuse, misuse, but what they physically do to the body. A certain percentage of patients get worse on higher dose narcotics as they get older. So we're always balancing how much narcotic use with our other modalities. So we watch them very carefully and teach them the safety of narcotics, especially if it's for longer term care.
Right. So is there any research or have you found any evidence, like if somebody is on, let's say, one Percocet a day, just to control some chronic pain, let's say before they go to sleep, and they're on that for 20 years, just one a day. Is that harmful or can that cause any problems long term on that low of a dose?
Typically not.
Okay.
But when combined with other kinds of pills that can interact with them, Valiums, alcohol even, we got to watch the overall safety.
Right.
So we can never let our guard down.
Right. And I'm sure you routinely test your patients to make sure that they're not abusing or...
And the safety and efficacy.
Right.
So, we trust our patients.
Right.
But there are new laws in place to watch them. Prescription drug monitoring in New York. We do urinary drug testing. They sign narcotic contracts.
Right.
So it's a working relationship. It's not supposed to be adversarial.
Right.
So we trust our patients very much, and we want them to do well when they're on long-term opiates.
Right.
And so that's working out so far.
Right. And what I find very admirable in your practice, which, by the way, where are your locations, Dr. K?
Smithtown, New York, and Shirley. Out east, we have two, and we work with Dr. Timothy Groth.
Tim Groth is your partner.
That's my boss.
Right. Gotcha.
Love him. Thank you, Tim.
But hi, Tim. How you doing? But what's basically cool about you guys is when you have a pain patient come into your office, even if they've been on narcotics for a period of time, even if they've had injections, you still recommend that they do things like chiropractic, that they do things like PT, like do things like exercise and physical conditioning. And you also refer me patients on occasions for manipulation under anesthesia or stretching under sedation as another pain management tool to maybe give them a little bit of edge where they can maybe not use as much narcotics if we have a little bit of improvement. I like that about your office. You're not just, hey, come every month, here's your script. You're always, am I right? You're always looking for different things.
You know why we don't do that? It doesn't work. You can't just use one modality. In my mind, out of the four basic methods, medication, injection, therapy, and surgery, therapy is number one. Chiropractic, physical therapy, wellness, mindset. Oh, but I'm still hurting. Then try some medications.
Right.
Narcotic, non-narcotic, muscle relaxants, nerve pills, anti-inflammatories. But I'm still hurting. Then try third priority, some shots.
Right.
But I'm still hurting, then go see a surgeon.
Right. Right.
Priority 1, 2, 3, and 4.
In that order, right. And what's really cool is a lot of people think, oh, well, if I take a pain medication, I'm going to be hiding the problem. I'm not going to be attacking the problem. But what most people don't realize is pain is a problem. And it can have effects on your body, as I talked about with that wheel of health, how it can make that wheel wobble. And no matter how hard you try, if you're not resting at night and you're up all night, squirming, not going into REM sleep, and your tissues aren't healing, you can exercise as much as you want. If they don't heal after you exercise, what good is it? You have tissue breakdown, right?
Yeah, it's okay for the wheel to wobble, but we don't want it to fall down.
We don't want it to just fall over, right? So for those of you in the audience, it's important that you realize that pain management is sometimes a valuable asset for your chiropractor, for your physical therapist, because there are times when we can't even touch you or try to manipulate you, or the therapist can't even try to get you to do an exercise because you're in so much pain. Whereas if somebody like Dr. K can just manage that pain a little bit, it might make our job easier and make that spoke of that wheel a little tighter, so they'd be able to now maybe have a better chance of getting across that bridge. So it's not just always hiding the pain, it's an adjunct to helping cross that bridge. Is that a good way to say that?
Yes, medications are both good and bad, as we were saying. They're good that they help control pain in conjunction with injections as needed in the therapy so that patients can rehabilitate.
Right.
So I wouldn't say it's a cover-up necessarily. Patients are anxious about that. We have to keep educating them.
Exactly. And then there are that class of patients that has such bad damage that they need that pain medication just to carry on their activities of daily living, and they're not going to get any better with the other modalities. I don't think that's a majority of the patients. I think that's a small amount of the patients. But in that situation, you might not cross the bridge and get to the other side, but you'll be able to function on the bridge and be able to enjoy your life, enjoy your kids, enjoy activities, enjoy events because of what you do.
Yeah. So chronic opiates, I agree completely. Chronic opiates, when patients are in it for the long haul, we're teaching them the principles of a lower dose, the least side effects for the longest period of time. Try not to escalate because of diminishing returns. Stay on it. Be safe as part of your program.
Right.
And live your comfortable, functional quality of life you desire.
Right.
It's very difficult to do.
Yes.
So it takes the specialists in the team to coordinate and teach the patients to stay on track,
Right.
to be compliant,
Right.
safety with opioids,
Yep.
lock them up, go to the same pharmacy, don't share them with their loved ones. Very important issue. So
Yep.
it's okay long term, even though it's very controversial in America with science and research saying
Very,
don't do it.
very controversial, yeah.
And clinical practice saying, hey, it can be helpful in selected patients.
Right.
So we use quite a bit of medication along with injection.
Right.
But still, it's therapy that's number one.
Right.
They need to be self-motivated to do well.
Right.
Home, exercise, gym, chiro, PT. This is the focus.
Right.
With us as the backup for their comfort.
Right. Right. Why is it that? Let me rephrase it. Are there any other doctors who do what you do that don't start as anesthesiologists?
Sure. There's the rehabilitation doctors and the neurologists.
They do pain injections and things like that?
They can if they're trained appropriately, yes. There's the fellowships now that have come out, early 2000s, and then in 2007 it became more coordinated between the three specialties of medicine: anesthesia, rehabilitation, and psychiatry and neurology. So we're doing a much better job at 1- and 2-year fellowships to train the patients as best we can, multidisciplinary, not just individually in their specialties. It's working better for America.
So you would say that to be a pain management, considered a pain management doctor, you have to have a 2-year fellowship?
A 1 or 2 year. Most are 1.
So if a patient goes, let's say to their general practitioner, and their primary care doctor, or they go to their orthopedist, and the orthopedist wants to give them an SI joint injection, does that patient know that that doctor has a fellowship, or should he, before he does that?
Not necessarily.
No?
Orthopedic is so widely trained in surgical and even interventional techniques.
Okay.
As long as it's meeting some standard of care that America has come to know.
Okay.
Fluoroscopic guided, with or without sedation, using an appropriate dose and frequency, not
Right.
abusing it. These are very safe.
So as long as the doctors have
injections.
had the training and their expertise and their regular schooling.
That's really what's happening. Selected orthopedists are very comfortable with that.
Right.
Neurologists, rehab doctors, even some internists. But the way that we're going, for chronic care, a lot are seeking the fellowship-trained physicians.
Right.
And the problem is there's not too many of us. Maybe 5,000, 10,000
In
for
the
an
whole-
entire nation.
How many in New York?
That I don't know.
Okay.
But Nassau has more than Suffolk County. The city has board-certified physicians.
It's just that I see most of the pain management guys I know were anesthesiologists to start.
We started it.
And so the anesthesiology group started it.
A natural tendency
okay.
after being in the OR treating acute pain
Right.
and trauma pain,
Right.
and having done epidurals and nerve blocks as part of our anesthesia training and clinical care,
Okay.
the fellowship was born
Gotcha.
by anesthesia, and the first fellowship awards were about 1993 for
Right.
fellowship training. So this is a new
So
process for America.
before that came out, anesthesiologists routinely in an OR, when a woman's going into labor, might be doing epidural. They may do nerve blocks if surgeons are operating on certain areas. So this is something an anesthesiologist would do even before this stuff came out.
Right, because they were naturally trained to do it.
And so it's a natural sequela those are the guys who do it best to begin with.
Right.
Gotcha.
So there was a John Bonica back in the day, the modern day anesthesiologist, birth of pain management in this country. He died in 1994. And that's just as I was finishing my clinical fellowship up in Worcester, Massachusetts.
Wow.
So I took the reins, and like a lot of other Americans, and here we are.
Do you find many of your pain management patients have psychological issues, chronic pain, depression,
Who wouldn't?
anxiety? And
It's a natural part of suffering.
Right.
Pain is both emotional and physical.
I'm sorry,
That's the way our
I missed
bodies.
that. Say that again?
Pain is both physical
Oh,
and
yeah.
emotional.
Okay,
That's
yeah.
how we feel emotionally and physically. That gives us the final pain experience.
Right.
So if we're not treating anxiety and depression, our pain is worse.
Right.
And if we're not treating our pain enough, anxiety and depression's worse. It's a vicious cycle.
They're tied together.
Just like sleep, pain, anxiety, depression,
Right.
hence wellness.
Right. And your practice, if you find that's the case, I'm sure you refer them out for psychological counseling.
At least half our patients have some element.
Good.
If we dive deep enough and ask them.
Right.
You can usually see that. And they'll
Right.
volunteer if they're suffering, if they're not making wellness gains. We'll say, hey, what's going on?
Right.
Why are we stuck in this rut? What's happening psychologically? You have to make an inquiry.
Right.
How is your sleep? Are you fatigued? Do you need to see the specialist, the social worker, psychologist? Do you need the psychiatrist?
Right.
Family members? Tom, if it's not addressed, they're not going to do fully well.
Right. Okay. Talk to me about sleep medications. Do you recommend those for patients?
Yes and no. There's different types. Short term, the common ones are Ativan, Valium, Xanax, or Lunesta, Sonata, Ambien, mostly prescribed by internists or short term with other docs. We do not like those drugs, especially when we're doing opiates. Other kinds of adjuvant drugs that can make you sleepy, we like to use. And this, of course, is if lifestyle changes aren't good enough or supplements.
Right.
There's other strategies for sleep.
Right.
But we can use drugs off-label.
You use nutritional supplements too? In your
Yeah,
practice?
kava. We can promote kava, chamomile, valerian root, any supplements that can induce sleep. But lifestyle, no caffeine at night, quiet, dark, cool room, comfortable bedding.
Right.
Then your prescription drugs.
Right.
We use muscle relaxants to make you sleepy.
Really?
Nerve pills to make you sleepy. Antidepressants.
Huh.
Off-label, but effective and used through time.
Right.
Elavil. Everyone's heard of Elavil.
Sure.
Great sleep-inducing drug. It's an antidepressant, but we're not treating depression. We're treating sleep issues.
Right.
And it also has pain-killing properties.
Really?
So we're using the benefits of these adjuvant supplement drugs
Uh-huh.
with opiates or without opiates
Right.
to help sleep.
Let's talk a little bit about pain. In my practice, I have people that are hyper pain sensitive. I touch them, they jump, they start crying. I have other people that I know are in severe pain based on their MRI findings, based on EMG testing, diagnostic testing, and I touch them and they have very little pain. So would you say pain is a brain-modulated subjective type of thing? which differs in everyone?
Absolutely. So that's the modulation emotional response to the very real physical nociceptive problem is how much the patient's going to show you.
Do you think it has to do with the way we're wired?
Yes, plus cultural,
Right.
very important.
Cultural.
How stoic you are,
Uh-huh.
or how not stoic you are. How much you believe that pain is real, or you feel, oh, I don't want to act sick because I don't want to be, I don't want people to look at me as if I'm disabled.
Right.
There's lots of things. So it's individualized.
When you said cultural, that reminded me of a very funny thing I saw once on one of these comedy shows, on one of these Comedy Central shows. Chris Rock was up there doing like a impersonation of what happens to a woman when she falls in public on a sidewalk with carrying a bag of groceries, and what happens to a man when he falls in public on a.
How does it play out?
So the woman walks along, she falls down, she gets up as fast as she can, picks up everything, and dusts herself off because she's hoping nobody sees, right? The man falls down and he's on the ground going, my back, my neck, my back. And it says, it kind of, I'm sure there's different cultures where they play these things out differently, even as far as the amount of pain they perceive, right?
It's so true. That's how we
Yeah.
are. That's human nature.
Right.
We try to help everybody.
Talk to me a little bit about somebody that has, you have them on opioid therapy, you have them on other pain management drugs, and now it's time where you have to now do what's called invasive pain management with your injections. Tell me about the different types of injection therapy there are,
Sure.
when they're used, for what conditions. Talk to me about that.
Sure. So different types of injections, minimally invasive to more invasive, short of surgery. So we're going to start with trigger points, muscle injections with local anesthetic for spasms.
And what are trigger points?
Trigger points are these taut muscular bands and muscles and tissue that when palpable, can cause patients to jump with pain, usually a chronic process. So we have chronic spasms. And
And those trigger points cause the spasms?
Yeah, the trigger points are the manifestation of the pathology.
Okay.
I've had one on my shoulder as one of my chronic pains for 20 years from
Right.
weightlifting.
Right.
They can be terribly painful, and then they can go away, and they can come back.
Right.
They
And we
can-
as chiropractors and also massage therapists, we get in there with our hands and we try to work on them and I was told they like build up of lactic acid within the muscle, and we try to get in there and dissolve them, where in your treatment you would get in there and inject that with something, right?
Right, to try to break the spasm with a local anesthetic mechanism
Right.
in conjunction with hands-on therapy.
Right.
So that's a trigger point.
Right.
Then, let's say you have a herniated disc, you need an epidural steroid injection to treat spinal inflammation with a minimally invasive injection in the epidural space.
And explain to the audience what the epidural space is, where that needle's going. So
Epidural, we've heard of that, women having babies. So now when you have a herniated disc in that same space, under an x-ray guidance with the patient on a fluoroscopic table, whether it's in an office or a surgery center or a hospital, you cleanse the skin with betadine, you numb it with lidocaine, and go to the dentist, and then under x-ray guidance, we take the needle, the epidural needle. It maybe look big, but it's skinny, and we go through the tissue into the epidural space under guidance through proper training, and we put a dose of steroid in the space. The steroid is meant to decrease the inflammation, to heal the disc, and break the pain cycle. Now, this can be repeated time to time, very safe and minimally invasive. A lot of patients are afraid, but as explained, it's very safe and minimally invasive. That's an epidural steroid, very safe, reproducible, and on an outpatient basis. Some people are nervous, they get sedation, but most can do it without it.
And when I see you working in the, I work with you in the surgery center. I do at my MUAs, you're doing your pain management. Do most of the patients in the surgery center get sedation, or they don't get sedation?
That is a 50-50. That's why it's there. Otherwise, we could do it in an office. But it's not so painful that you have to go to sleep for a procedure, like an epidural. There are things we do that are more painful, and you will have a sedation if you're burning nerves or doing other more invasive things. But for the most part, epidural can be done without sedation, but up to the patient.
If the patient is nervous, they're a little apprehensive about the procedure, they may say to you, hey, you know what, I don't want to feel anything.
It suits them well.
And that sleep is like a twilight sedation, right?
Twilight,
They're conscious.
much like MUA.
Yeah, they're conscious, right?
Right. They can talk to you. Some are deeper than others,
Yeah.
but just like MUA.
Yeah.
Sedate them, do your thing,
Right,
safe, outpatient, let them go home.
right. And are there any risks or complications with that procedure?
Sure. Any procedure.
I know any procedure has, but what are the risks of that procedure?
The epidural per se?
Yeah.
Bleeding, infection, nerve injury. It doesn't work. You have procedure pain, drug reaction potentially.
That's a
screening.
Very rare occurrence, right?
Most are rare.
Yeah.
But the patient says, "Well, it didn't work." Well, you can't really call that a risk. Sometimes they work, sometimes they don't.
Right.
But you select your patients. If you're on blood thinners, you're not injecting the spine. You can bleed and have an epidural hematoma and have nerve damage. Hello.
Exactly, and that's the same way we select our MUA patients. Somebody's an uncontrolled hypertensive, uncontrolled diabetic. Somebody has a gastric problem where we're going to put pressure in their abdomen. We select our patients the same way and assess the risks. So
that's the key.
Well, Dr. K, I'd like to thank you very much for being my guest today.
Pleasure.
For those of you who are watching us on Madhousetv, stay tuned. We'll be right back. For those of you who are watching us on Cablevision, we'll see you next time. And in closing, so if you want real wealth, join us next time and cross the bridge to health. Have a good day.
So this little old lady, she comes over to me and she goes, "You're never going to be successful unless you follow Jesus." I said, "I would follow Jesus, but I can't walk on water." "And by successful, you mean mounted to a cross? Because he nailed it." "Why aren't any of you laughing?"
Because we're watching Madhousetv.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hello again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow, and it's my honor to have Dr. K, a pain management doctor, with us back again for this show. Hi, Dr. K.
Oh, hello, Tom.
Thanks for being with us again.
Sure. Pleasure, thank you.
So on our last show, we touched many different topics, and we started to touch on the techniques you use, which we classify as invasive pain management therapies. And we talked about epidural injections to help the spine. Let's talk about some other injection therapy that you do. Can you tell us, the audience, exactly like what sacroiliac joint injection therapy is, what the joint is, and what the injection tries to accomplish?
Sure. Sacroiliac joint connects the hip with the spine. It's like a knee joint, an ankle joint. It's got synovial lining. It can be susceptible to degeneration, trauma, and it can get quite inflamed. So by way of techniques, if the therapies and manipulation and chiropractic and the medications are limited, we're going to put steroids, with or without local anesthetic or other substances, into the joint under x-ray guidance, with or without sedation,
Right.
minimally invasive, outpatient, to decrease inflammation and to speed healing.
Right. And what I find is, if we have a patient who's got a really inflamed sacroiliac joint in my clinical chiropractic practice, we can try as hard as we can to try to get that joint to move and realign it. And sometimes there's just so much fluid and swelling in that joint, we have very limited movement that we're able to accomplish to make a correction. And that after we send the patient to someone like you, number one, they get pain relief. And number two, that inflammation is cut down, and we're able now to adjust them and make the correction easier, so they can get across the bridge
Sure.
and have better health when we're done.
Right.
So
Right.
again, as we explained to the audience in the last show, your treatment isn't just to hide the pain. It's sometimes, and most of the time, is treatment which enables other parts of our team to be able to go
Right.
on to the next phase.
It's indeed therapeutic.
Exactly.
And it can be diagnostic too. Sometimes you don't know if it's coming from the joint, the pain.
That's
There's so many different things in the spine that hurt.
You know what?
All in the same area.
That's really interesting that you said that, because I had a patient come in the other day, had every diagnostic test done you could imagine, but he still had severe headaches after a car accident. He still had severe neck pain, suboccipital, and for the audience, that's the base of the skull.
Right, base of the skull.
And he actually went to a pain management doctor who gave him an injection in his suboccipital muscles and fibers. And what he told me was the pain went away for 4 or 5 days, but then it came back. So in that particular case, to me, that was a diagnostic test.
And therapeutic.
But more important to me at that point, because it was my first time seeing this guy, is it helped me make a diagnosis that indeed this is an occipital type muscle type problem. And when I went to examine him, he had very little movement between his first cervical and his occiput, and a lot of tension and scar tissue between the two. So I knew he was probably a good candidate for MUA, which is manipulation under anesthesia.
Sure.
So again, as you said, a lot of your techniques are not only therapeutic, but they're diagnostic too.
Right, so they help the whole team.
Right.
So this gentleman you were mentioning, he may have had greater occipital neuralgia with myofascial scarring. You go to atlanto-occipital arthritis,
Right.
scarring.
Yep.
So MUA good.
Yep.
Injection good,
Yep.
if it didn't last. And then there's a follow-up procedure for the nerve if you want to keep it quiet for even longer.
What is that?
Radiofrequency lesioning.
Okay, so that's
Ablation.
That was the next
There
thing.
are more techniques.
That was the next thing I was going to talk to you about. So what is RF ablation, radio frequency ablation? Explain to the
Right,
audience
right.
exactly what that is.
So we use heat. Heat can denature, it can block nerves, much like local anesthetic and steroid, but typically for a longer period of time. So say you have nerve injury at the base of your head, or nerve injury in your facet joints, these joints along your spine and your neck or back. If there's nerves that control pain. If you're Conservative therapies are limited, your medications, your injections of local anesthetic. Then radiofrequency lesioning using heat can be safely done with probes, outpatient, under sedation, live x-ray, placing these probes in specific areas along the nerve and then heating them, say 80 degrees Celsius for a minute and a half time.
What is that Fahrenheit, Dr. Ken?
Fahrenheit, too high. You'll
You'll burn.
You might catch fire. No. So radiofrequency lesioning blocks the nerves. They do grow back. You can have your pain come back, but it's typically months and months rather than just weeks of relief or days like this gentleman you described.
So it actually is eliminating the nerve endings which generate pain that the patient feels.
Right. You're blocking them.
But you're not blocking.
You're burning them.
But you're not blocking any nerves that would make your hand move or any motor nerves. Or
Right.
anything
Good
like that,
point.
right?
Very safe. Right. Good point. You're not blocking spinal nerves that are going to leave you paralyzed or with numbness in your legs. Those are not nerves to be burning.
Yeah, because when I first heard of this as a practitioner, I'm like, wow, what's the risk of that, damaging some other nerves in and around there? But I'm sure with your guidance techniques and where you're doing this, you're only hitting the sensory ends of the nerves to give
Correct.
the patient pain relief.
Right.
Awesome. Okay, what is a spinal cord stimulator, and when is that used?
Spinal cord stimulator? That's almost like an internal TENS unit, the trans-electrical nerve stimulation you might use in physical therapy. But this device, it's a wire or two. It's placed in your epidural space. Again, under x-ray guidance, sedation, outpatient setting, through needles. It doesn't have to be surgery. It's minimally invasive. It's not surgery. But a trial of a spinal cord stimulator, if I will, is two wires in your epidural space hooked up through your skin to a TENS unit, a generator outside, and you're using sensations to block nerves. Blocking nerves can block pain as a substitute for your real nerve pain on a trial basis for 7 days to see if it helps your pain. It's a trial. It's going to come out. If you love it, if it really helps your pain a lot, you can put a permanent system in, and you can charge it once a week. But it's a very sophisticated device. It's for a more advanced pain patient, not from the get-go.
So let me understand this a little better. So when you do the trial stimulator, you're just making some incisions and putting wires into the inside of the spinal canal, into the epidural space, and that's all that's inside the person's body.
Yeah.
The
Sometimes you don't even need
actually is
incisions.
What's that?
Sometimes you don't even need incisions. You just put them through needles.
Okay, wow, interesting. And so the person wears this stimulator unit outside their body, and they adjust it to regulate their pain.
Yeah, typically with a representative in conjunction with a doctor.
And if that works, then you take that unit that's outside their body and you implant it inside their body, correct?
Right, at another time. Again,
Right.
safe, outpatient, minimally
So
invasive.
now again, everything is inside. They have no wires coming out of them, and they have some type of controller, wireless controller outside their body, which regulates the stimulator inside their body, correct?
Right, you can turn it up, you can turn it down, you can shut it off, you can adjust it. You have different programs you can learn. Wonderful technology, lasts 40 years.
And do you find that works most of the time on a lot of these chronic pain patients?
Well,
Is it good results?
50-50. I always say everything's a 50-50. The pill's going to be 50-50, the shot, well, hopefully surgery is not 50-50. But
When they go through an airport, will a metal,
That's why it's tested.
will a metal detector go off? It will?
well, you have to have a card, you have to have a special bracelet.
Okay.
You got to go through security.
Is there any risk to something messing that up? Like I know of patients where if they have defibrillators implanted, we can't do e-stim on them or anything like that.
Right. You don't want to burn it.
Is there any type of risk to having that inside of you? Things you have to-
Diathermy, there's certain procedures with cautery you can't do. Right, so even MRI issues.
Can you do an MRI with that in?
Well, some are MRI conditional, and some more like do a CAT scan if you have to. It's becoming an issue, and a couple of good companies, one has a conditional, one has a non-conditional.
Right.
But it really, does the stim help them? There's
Right.
terrific companies, you can do either one. But does the stim actually help them?
Right.
And you're individualizing it and making a decision what system to put in them.
Now, when you say that stops the nerve transmission of pain to their brains, how does that actually work? I mean,
We don't really know.
we don't really know, right?
We don't know. It's still science and research. There's theories.
But we know it works, but we
You're
don't know.
blocking the gate theory. You're blocking transmission of the spinal cord to the brain
Right.
through the electric impulse, like a TENS unit might. We may never know,
Wow.
but we know it works.
Right.
We know electricity treats pain.
Yep. Yep.
It happens.
So I have a patient of mine who was in a very, very, very good friend of mine, very severe accident in which he lifted a manhole cover, herniated his L5S1 disc. I mean, to the point where the whole canal was totally obliterated. He ended up with for the audience, a condition called cauda equina, which his bowel functions affected, his urine functions affected, those parts resolved, but the guy has gone through every treatment possible, epidurals, he's gone through ablations, he's gone through implanted stimulators, all of which have failed, and now they're suggesting he gets implanted a morphine pump.
He never had surgery?
Oh,
this
yeah,
patient?
yeah, 3 surgeries.
3 surgeries for the acute situation.
Yes, 3 surgeries. Can you explain to the audience what
Morphine.
morphine pumps are? And that's like the last step of all this, right?
It's the Cadillac of administration of pain-relieving substances directly to the spinal fluid. We talked about the stimulator being outside and using electric in the epidural space. A morphine pump, again, once tested to see if patients can respond to morphine through a single dose or a continuous infusion of morphine in the spine in an inpatient or outpatient setting. There's different ways to test morphine in the spine to see if a patient's going to respond. But if they do, again, through an outpatient procedure with a small pump implanted under the skin filled with morphine, that's regulated. It can drip morphine directly into your spine through another tube and give you continuous pain relief. Again, very fancy stuff for most patients.
How is
You
that
have to be
regulated?
really advanced.
Is that regulated by the patient
It can be.
and based on their
They
pain?
can give themselves their own boluses.
Can they get addicted to that type of morphine?
It's much less likely because you don't get a big systemic effect and a big high effect like you can with oral medicines,
Right.
so it's not a major issue. And if they're addicted, then they're not going to even be a candidate for any opiate because you can't have a morphine pump without failing typically oral or transcutaneous opiates. You don't just put a morphine pump in.
Yeah, this patient's
You have to
failed a
fail
lot.
a certain
He's been
level
on
of
oral
narcotic.
morphine, it really
Right.
hasn't helped them.
So typically 300 milligrams of more of oral morphine, there's no direct cutoff,
Right.
you become a candidate for a pump, which
Okay.
is 1 milligram of morphine in your spinal fluid.
So
That's
again,
how strong it can be when it's
So
right in
again,
there.
I'm going to get back to kind of what I touched on the last show. When that morphine goes in and into that epidural space and it hits the nerve endings, how does that not sedate the motor ends of the nerves? It's just sensory nerve effective?
Just sensory. That's all morphine does. There's no local anesthetic.
Okay.
If you put local in the pump, which many practitioners can,
Right.
then you're at risk of blocking more sensory and motor, but not morphine alone.
Okay.
Excellent
Interesting.
question.
Tell me about, because I'm curious. You tell me and I'll tell you. In all your years of practice, the most challenging and difficult case you've had.
Right.
Or-
I've had a couple. Sad case. When I was at the Syosset Interventional Pain Center, we had a young woman dying of pancreatic cancer. 2 kids, you know the whole story, young,
Yeah.
whole life ahead of her. And she had failed the medications, the therapies, she was doing the chemo. I don't believe she had had surgery, advanced case, or if she had, it came back.
So she had cancer pain.
Yeah, she had cancer pain. And, I believe she did have a resection. She thought she was cured. It came back many years later. A lot of family involvement. It was very difficult.
Okay.
So when it came to interventional pain,
Right.
my job was to try to help her with the short amount of life that she had left to really die comfortably, or at least to try to make sure that she didn't suffer at the end of life with chronic
Right.
cancer pain, big
Right,
problem
right.
in this country. So we ended up doing a diagnostic therapeutic local anesthetic injection to block nerves around the pancreas called celiac plexus. And then we ablated them with alcohol to try to give her some comfort. And indeed, in her
Helped
dying days, it helped her with this very difficult, sad situation as palliative care.
Right.
On a brighter side, with non-cancer care, another patient had both neck and back pain, circumferential around accidents, and it was a prolonged workers' compensation case, and she went through everything. All the medications, the narcotics, the nerve pills, the muscle relaxants, all the injections, all the therapies. She even had fusions of her neck and back. She even had a spinal cord stimulator in her neck and back. And then finally it settled down. She went the whole gamut, but persistence,
Right.
multidisciplinary care, keeping her brain in it.
Right.
As tough as it was, she got through it.
Good.
And that's that speaks to the human spirit and never give up
Absolutely.
and have the bridge to health work.
Yes.
She crossed it.
Persistence
Persistence,
and not giving up.
not giving up.
Some of the most difficult cases that I've had come through my office, which come through yours all the time, are people with fibromyalgia and people with RSD. Can you let the audience know, explain to them first what those two conditions are, and how you come in as a pain manager doctor with those?
Sure. Two very different conditions. RSD, reflex sympathetic dystrophy, the original term, now termed complex regional pain syndrome, CRPS, typically afflicted neuropathic, musculoskeletal, and can come with injury, trauma, surgery of the limbs, upper and lower, horrific nerve pain, very difficult to treat, not like a broken bone, very bad. Sensory findings, sensitive skin, can't touch, hot, cold, swelling, stiffness. What are you going to do? So this very bad neuropathic pain has the options, the medications, the injections, the therapy, and the surgeries to try to break the cycle and put it into remission. Very difficult. It's not like a herniated disc, it's not like a muscle pull, it's not like a joint pain. So these very difficult conditions, which my partner, Dr. Groth, is an expert at here in Suffolk County, and he sees a lot of patients with RSD. We tried to help them. Stimulators, we talk about the spinal cord stimulator. If you don't get better with more conservative, can break that pain cycle and make you feel better. So RSD is nasty, very difficult to treat.
What causes
but can be.
What causes that?
Well, that's the thing. We're not completely sure how the nervous system turns on itself. There's a couple of different theories, but picture this. You have pain. You prick your finger. The pain sensations come up into your spinal cord, up to your brain. Okay. Now with RSD, with injury, there's a rewiring of the circuitry, we think, where now instead of just having a normal hurting pain, if you just stroke your hand, which is not supposed to hurt, now causes reflexive pain, if you will, into your spinal cord, into your brain, and now you're hurt. Now you have this proverbial circuit that we need to break. You need to break that circuit to treat the pain. So that's why we have our pills, injections, therapy, and surgical techniques, and stimulator techniques.
But we really don't know why. In other words, I have a patient come in, they've got a C6, C7 herniated disc. Neurologically, we confirm it that it's a C7 nerve root problem, but it just doesn't affect their middle finger. Their whole arm is hot. You touch it, you stroke it. Neurologically, it makes no sense to us as clinicians, and then they're eventually diagnosed with RSD. So is what you're saying that the brain kind of like rewires circuits?
It can. And the nervous
so the
system.
brain thinks it's the whole arm where...
Peripheral and central. Sensitization, we call it, this kind of rewiring. Yeah, no, for sure. There's certain diagnostic criteria to try to help clinicians make a diagnosis of RSD.
Is it a bone scan? Do they use that to confirm that diagnosis sometimes?
It was thought that it would be important to do, but it's not necessary for the diagnosis.
Okay.
Because with this sympathetic outflow, you can have demineralization
Oh, is that
of
why they
joints
use,
and
that's
bones.
why they use the
So
bone
it
scan?
may help, but it's not necessarily conclusive.
Okay.
Just like there's no blood test for pain
But I
in
think
general.
what you're saying is if you suspect RSD and you do a bone scan and the bone lights up in that part where they're hurt, it's diagnostic, but they might still have RSD even if it doesn't light up.
Correct.
Gotcha.
Yes, if you have the pain, the swelling, the stiffness,
Right.
the other kinds of physical and symptoms that you have,
Right.
and no other explanation for the pain, no other disease model. It's
Right.
like a diagnosis of exclusion,
Right.
and it's like you have pain. It's like you have this incident of pain, like something happened to you,
Right.
or as innocuous it was as a sprain, or a major surgery, or a nerve injury.
Right.
You can still have it.
Gotcha. And fibromyalgia, years ago, when I started practice, it was a psychological diagnosis. Was it this, you remember
Because
those
we had
days?
no other physical reason to explain it.
Remember those days? Yeah,
Well,
so
it had a lot of different names,
a lot
but
of
it's
different
real.
things. But now we know it's real.
Sure.
Is there any definitive diagnostic test to diagnose fibromyalgia?
No,
It's just by clinical
hands
exam.
down.
Clinical
Like
exam.
a lot of pains.
Right.
Clinical symptoms, again. Yeah, fibro's come a long way. We have associations now, rheumatology subspecialty. Yeah, fibro soft tissue, it's very difficult. Stress, infection, what brings it on? Women more susceptible. Sometimes it can go away later in life. You can overcome fibro. You don't have to live with fibro the rest of your life. But very difficult. Chronic fatigue especially.
I've read several articles and several books where they try to link, I think they found a link of some sort to like kidney function and nitrogen balance. Have you read anything about that?
No.
Yeah, where the nitrates get deposited in the muscles because they're not removed or something like that. Yeah, so there is research out there going, and then there's certain diets they go on or certain supplements they take which help flush that out. I just wondered if
Could be incidental finding.
Yeah.
But hard to do hardcore research on,
Right.
again, pain in general because it's so
Right.
subjective.
Right,
But with fibro, you may have no discernible problem.
right.
You may have no discernible problem, but still be afflicted by fibromyalgia.
Are those
so very
patients,
difficult.
are those patients usually fatigued?
Yes.
Very
Fatigue, irritable bowel, memory loss.
Right.
Yeah.
Memory
And-
loss too.
Yeah, and there's very little, if you think about it, to offer other than the physical aerobic capacity of a patient. They need to do that. Think very positively because it's a lot of mind-body, and then take your fibromyalgia pill sequence, of which there are 4 basic ones.
What are they?
Savella, Neurontin, Lyrica, and Cymbalta.
Okay. And I've, in my research, I've read that part of the clinical diagnosis is they actually give you a chart of a body and there's points, and if they have X number of points out of so many points.
They're tender points.
Yeah, tender points. Do you ever inject those points?
It's,
Like trigger points?
They're not triggers.
Oh,
they're
so
not
you-
muscle
so
tight
you
bands.
wouldn't inject them.
So you don't typically. But yes, the 11 out of the 20,
Right.
so many.
Right.
Again, that was original thinking. You don't necessarily have that with the new modern way to classify fibromyalgia.
Okay.
It's not necessary.
Okay.
But it helps.
Okay, so we've talked about, again, condition types in your practice you treat. We've talked about pain post-trauma. We've talked about in both acute and chronic. We've talked about fibromyalgia. We've talked about RSD. We've talked about cancer, pain. What other types of conditions might you treat? Are there any others besides the ones we've talked about? Disease processes?
Well, medical disease processes are typically your neurologist, rheumatologist, internal medicine.
Right.
Gastro problems are usually the gastroenterologist. Migraines, maybe usually the neurologist.
Anything for like diabetic neuropathies?
Well, sure. I mean, the neurologists are trying, but again, difficult. You need to control diabetes, number one,
Of
to
course.
minimize neuropathy.
Of course.
But then you have your neuropathic medicines. Sometimes injections,
Okay.
therapy always,
Right.
and not typically surgery.
Okay.
So that's a chronic medical. But think of it, podiatry has to treat feet, the orthopedists are mostly doing joints.
Right.
It's really this team effort.
Right.
So as anesthesia in our private practice, we're mostly doing spine,
Do you
but we
inject-
can advise on everything.
Okay. Do you inject in extremity joints too? In intra-articular?
Sure.
Like within the
If
joints?
the orthopedics are not doing it,
Well,
or if the rheumatologist is not doing
Okay.
it, if
I
they
know
want you to
orthos
do
normally
it.
do that. I was
Sure.
wondering if you did that too
And
in your practice.
rheumatology and us.
Okay.
We'll do it under X-ray with or without sedation. We
Right.
can put local and steroid in joints.
You do
to
it under
treat-
sonography sometimes too, right?
You can. We have the fluoro unit right in the
office.
the live X-ray now. Can be quite effective. Look, you put an anti-inflammatory in joints. If you have a lot of inflammation, you're going to feel good.
Right.
Otherwise, you're going for a surgical procedure.
Right. We've talked about the disease model, and it's interesting, your perception of that and the reason why we need to think that way. Can you kind of extrapolate that and explain to the audience what you mean by pain as the disease model of pain?
For all those that are looking, this is a very important critical point. Pain management, as subjective as it is, can't be measured. So we need some kind of objectivity. So where we're going in America and really around the world with the concept of chronic pain, because it's so subjective, to keep it real for the patient and the healthcare pain providers, we're going to think about chronic pain in a disease model that's serious, that needs to be treated like any other chronic disease, blood pressure, diabetes, asthma, lupus. We need to take it very seriously and offer lifetime care, just like any other disease process. Lifetime care, because it's not going anywhere. Everyone thinks we're going to get cured, and we're not. I'm a chronic pain sufferer for 20 years, knee and shoulder from sports injuries in medical school. Disease model. Take it seriously and offer the different modalities. medications, injections, therapies, surgery, psychological care, restful sleep, complementary alternative techniques. Get your best care from the very best people you can, and you'll do well. But be compliant, because disease needs to have compliance. Like if you're not taking your blood pressure pills, your blood pressure's out of control, you can have a stroke or a heart attack. If you're not taking the diabetic insulin, you could have a diabetic coma and do poorly, you could die. If you're not doing your pain management program, your disease model chronic pain management program, you're gonna suffer to no end and be disabled and be more reliant on people. So the disease model keeps it real. And if you can buy into that and believe that, and your healthcare providers take it seriously, you'll be fine. Very hard to do. We do it expertly here.
So Dr. K, once again, I'd like to thank you for being my guest. You did an awesome
I enjoyed
job.
it. I enjoyed it very much.
I think the audience totally enjoyed what you had to say.
I think we've taught them a
And
lot.
again, where are your offices located again?
Smithtown, New York, Shirley, New York. One in out in the west and one in the east, here in Suffolk County, Long Island.
You're in Smithtown on Jericho Turnpike. Good.
Jericho Turnpike and William Floyd Parkway in Shirley.
Any of you folks who'd like to get in touch with Dr. K and Dr. Tim Groth, they're excellent pain management doctors that are part of our team, and they'll take exceptional care of you to help you cross that bridge. Well, once again, thank you for joining us, and so if you want real wealth, come join us next time and cross the bridge to health.